There you go.
About Cannabis Public School, and welcome, welcome, welcome to everyone. Our mission is to ensure that everyone across America has accurate information about the holistic benefits and the potential risks of cannabis. We advocate for increasing acceptance of cannabis therapeutics among conventional healthcare providers, which is a continuous act that we all must work towards and on to enable our healthcare consumers feel supported in deciding how they take care of their own health. We embrace the spiritual and recreational value of cannabis. And just a brief pictorial of my last month. I myself have moved back to the land. I've become a back to the lander in my own sort of way. I moved back to my little cottage in Fort Bragg. That's my madrone. I have some other things that I've put in the ground and really excited to do more. So that's that. Let's see. Once I got home, I went up to a Canna Mom retreat where I was able to give a little, just a couple of little educational talks about menopause, perimenopause, estrogen, the importance of estrogen, and what happens when estrogen is in lack. This is at Soul Spirit Farm, and this is where I got to spend 4 glorious nights. We did some sound healing under the stars. This is, I have often said that this is the way I thought my life was going to be. And now I am at Emerald Cup in Oakland, meeting some amazing medicine makers. They're doing some regenerative farming guild sessions, seed swaps. I'm with Adelina Sanchez, as some of you may know, has been a longtime supporter of Cannabis Public School, and she came out to join me in Oakland, and we are working together here. So that's very special. I met her online. This is more of a Canna Mom retreat where we swam in the river. This is the ethnographic study of the political geography of California cannabis. It is a 3-year study put on, I think, in coordination with Berkeley. Maybe anyway, it's a 3-year funded study about cannabis and community. The study is called People and Their Plants, a community-driven study by the Legacy Cannabis Genetics group. So it's an amazing, amazing progress. Looking forward to what they are going to pull off. Okay, so that's where I've been. I have been like a little bit befuddled. I've been in the, but I'm here now with Janna, and let me introduce our speaker. When I disappear, it's very purposeful. Janna Champagne, I'm going to have you talk about your initials after your name. She is a professor of integrative medicine, teaching medical cannabinoid science at John Patrick University, a board-certified master herbalist, a diplomat of medical cannabinoid science, and a retired nurse. Janna's introduction to the cannabis industry began in 2012 as a cannabis patient who happened to be a nurse and experienced profound benefits. Janna is also known for her success in treating her daughter's autism with cannabis, and this became a cover story in a national industry magazine in 2017. Janna has educated thousands of patients, helping them optimize their cannabis therapy outcomes through an individualized and well-informed approach. This naturally evolved to educating medical professionals with accredited and university-level content. Janna also helps create herbal and cannabis formulations and is a published author. As a contributor to the American endocannabinoid medicine, the American Journal of Endocannabinoid Medicine, Janna brings a nursing and herbalist perspective to the 1.5 million subscribers. Janna is a founding member of the Cannabis Nurses Network, served on CNN's Speakers Bureau, and has been awarded every year since 2019 with designations including Leader of Nursing, Outstanding Author, Educator of the Year, and Contributor of the Year, plus an honorable mention as Nurse Mentor of the Year. We can't thank you enough, Janna, for being here. Janna volunteers on the Oregon's Ryan's Laws team and the Oregon Cannabis Healthcare Act Coalition, and she is founder of the executive directors of the board for a nonprofit Autism Safe Haven. So for more information and to visit her Media Kit website, go to www.jannachampagne.com. Janna, if you will, please take us down the rabbit hole.
Yes, of course. Thank you, Mo. It was a wonderful introduction. I really appreciate it. And I'm excited to be here today. So thank you everybody for joining us. Mo kind of covered a lot of my background. The letters after my name stand for Board Certified Master Herbalist, Diplomate of Medical Cannabinoid Science, and then of course Bachelor's Science in Nursing. And I'm a retired RN as of 2022. I actually retired my license in boycott of unethical policies on the part of my Board of Nursing. So we'll get a little bit more into that story today as well. So thank you for joining us today for Educate and Advocate. This, of course, is in cooperation with Cannabis Public School. These are some of the learning objectives we're going to review today. The importance of educating medical professionals on cannabinoid science. And I really feel like this is a lot of what's wrong with our medical cannabis industry today, is that our medical professionals are not educated on this topic. So we're literally omitting the endocannabinoid system that we discovered in 1992 from anatomy and physiology and pathophysiology courses, where it should totally belong in 90% of medical and nursing school curricula. So this is a huge problem. We actually have research supporting that cannabis patients experience improved outcomes when they have competent medical guidance, and we're really lacking those resources because of the lack of education. We're going to cover some common misconceptions and education strategies for helping to crack open the paradigms of naive mainstream medical professionals. These are some of the tips that I've learned over the years, over the last decade doing this work. We're going to talk about medical cannabis advocacy needs. We need support for cannabis patients and the medical professionals serving them, which is currently lacking even where I live in Oregon, where we've had legal medical cannabis access for more than 25 years. This is still an issue. And we're also going to review a successful advocacy story that I experienced with the Oregon State Board of Nursing. Now, this course does have one CE available for completion, and you can talk to Mo after the fact. I believe she's going to send out a survey, and once that's completed, you can get your certificate if that's something that's helpful to you. So as we go through this too, if you have any questions, please just jot them down or put them in the chat, and I'll get to those at the very end. It kind of helps me keep on our time frame today. So thank you for that. A little bit about my journey. I'm a cannabis patient who happens to be a nurse. I'm also a special needs mom. I have a daughter with autism. We have both experienced really profound benefits from medical cannabis therapy. And it's our health outcomes that really drive my passion for working in the cannabis industry. And really, all I've really done is follow cannabis patients' unmet needs, and they're so profound. I mean, I laugh when people in this industry are competitive because there's plenty of work for everybody. Like, there are so many needs that need to be met. And my first role, well, after 2012, became a patient. In 2014, once I was beginning to recover, I began growing and caregiving for other patients. So that was kind of my first official role in the cannabis industry a decade ago in 2014. And you can get more information about my story and my daughter's story on my Media Kit website. So what following patient needs has really led me to do is lots of things. These are the things that I think are most applicable today. And I'll just review them quickly because I know Mo already talked about some of this. But I began doing patient education in 2014. I've served thousands of patients through my business, Integrated Holistic Care, helping them optimize their cannabis therapy outcomes with a really well-informed approach. So I'm a clinical application specialist. I also mentor other medical professionals and nurses to help them learn that craft. I offer free nurse guidance through Cannabis Nurse Approved. I'm an author. I've contributed to the first textbook for nurses by Carrie Clark for teaching the endocannabinoid system and cannabinoid science to nurses. I also write for the American Journal of Endocannabinoid Medicine, so I've published several articles with them. I'm going to talk about kind of how this happened, but in 2019, I pivoted from just educating patients to educating medical professionals. And my first accredited content was actually in 2018 at the Oregon Holistic Nurses Association conference. So I've been doing this for a little while. In 2020, I became a college professor and I teach graduate level or undergrad level for a graduate program cannabinoid science courses. I also am very involved in nonprofits, and I am really trying to trailblaze cannabis inclusive autism care in Oregon and in all legal states through Autism Safe Haven. And then I do a lot of patient advocacy through Oregon Cannabis Legislative Advocacy and with the Board of Nursing as well. My daughter's story published in 2017, and you'll see here on the right, was kind of my coming out of the cannabis closet moment. You'll notice I was still calling myself a holistic nurse, not a cannabis nurse. If you're interested in her story, there's a link there to read her article as well. And all of these links were sent out in notes with all of these slides on them as kind of a note-taking template. And because it's a PDF, you should be able to just click those links and open these right up. But if you have any questions after the fact or need citations or some of these links, you're welcome to reach out to me as well. Some of the common misconceptions we run into in naive medical professionals. And I'm going to kind of talk about some of the reasons for these as well. So naive medical professionals may believe that cannabis is a snake oil or a fix-all. And this comes from the fact that they don't understand the endocannabinoid system. They don't understand that it's the motherboard of our body and that its job is to maintain homeostasis or optimal health balance in every other system of the body. Now, the underlying cause of all disease is imbalances. So the fact that the endocannabinoid system naturally addresses that makes it a great fix for a lot of different conditions. And of course, we have more than 35,000 reputable research studies supporting cannabis for dozens of conditions, and this is why. But to a medical professional that doesn't understand the endocannabinoid science, because they haven't been taught about it, so in their defense, they haven't been told this information, they hear cannabis is good for all of these things, and they automatically think it's snake oil. It doesn't fit into this paradigm of what they're used to, which is the pharmaceutical approach, which is very targeted, very usually singularly focused. So it's a completely different paradigm for them. And really the fix is education. Some of them are afraid of cannabis because it is federally Schedule I placed, meaning that the criteria for that is that it must be highly addictive, it must have no accepted medical use, and it must be harmful or potential for harm, I believe is how they term it. So they see that federal Schedule I, this sounds like a really scary substance, this cannabis thing. And some physicians believe that they need a special license, a Schedule I license, in order to prescribe cannabis. So there's a lot of misconceptions around how this piece impacts our patient care. And what they don't realize is that we have research reflecting that cannabis is less physically addictive than things like caffeine and sugar. We have our medical government that holds patents, including the most infamous 6630507, specific to the medicinal uses of cannabis. So clearly, those two criteria don't fit. And then harmful, the DEA itself, still to this day, you can go to their website and it proclaims that there have been 0 deaths ever attributed to cannabis. So clearly not harmful, especially considering that we freely allow things like opioids that are killing patients every 11 minutes today, correct? So there's a lot of hypocrisy around this and a lot of misinformation. So once again, just educating and saying, hey, look at this, look at that, look at this. These are facts that counter this federal Schedule I placement being a viable, restriction for cannabis. It really should be freely available. So another misconception is that cannabis use changes baseline motivation and decreases function. We do have research on this. They did a cohort of college students, and what they found is that cannabis use didn't change their baseline motivation. So this is another misconception. And I also follow this with that, yes, we have problematic cannabis use sometimes, but it's not the patient's fault. They don't have competent medical guidance most of the time. So they don't understand that maybe they should be taking the non-intoxicating compounds during the day so they can be optimally functional and take the intoxicating stuff at night. I mean, we can do some really simple education and guidance for these patients to help minimize the risk of things like cannabis use disorder and cannabis hyperemesis syndrome. So once again, solution is education. Allowing cannabis in medical settings risks loss of federal funding is another really common misconception. This is one I'm up against the cannabis licensing board for care homes and facilities right now who believe this misconception, and because of that are actually in breach of a Oregon state law that protects patients' access in a medical setting by saying, a caregiver can't touch a cannabis product when the law says the patient has the right to all aspects of cannabis care. So it's really, this loss of federal funding through Ryan's Law advocacy. We did get a written confirmation from federal CHS saying they never have and they never will withhold federal funding to a state organization that is operating within their state law and providing accommodations to cannabis patients. So we have that in writing, and this is still a fight. Many of them believe cannabis patients don't require medical oversight. And it's unfortunate because this is in direct breach of our medical ethics. They believe that daily cannabis use is cannabis use disorder. That's one of the DSM criteria, where we can counter that with education and explain that some patients have a deficiency that cannabis can help fill. And in those cases, daily use is actually very appropriate.
Mhm.
Some people believe that Oregon laws and the Oregon State Board of Nursing lack support for nurses serving cannabis patients, and this is beginning to change. So we'll talk more about that moving forward as well. So this is my experience having worked with thousands of patients on what we can expect for patient outcomes. Now, this is with competent guidance. We often see reduced reliance on pharmaceuticals. And with that reduction of pharmaceuticals and their prolific side effects, we see improved quality of life and function. We also see de-escalation of acute symptoms. I'm one that was able to be spared from needing opioid pain medications thanks to cannabis, which is a harm reduction, right? Because opioids are deadly, cannabis is safe. So this is where that risk versus benefit comes in. And I often teach that this is how we uphold our medical ethics with patients, is by constantly comparing the risk versus benefit of all of their potential treatment options, including cannabis when it's available. And cannabis is often the least risky and the most potentially beneficial because it has that unsurpassed safety profile, not all these horrific side effects that are impairing quality of life and function. Plus, it has the ability to target the underlying contributors to disease by promoting homeostasis, which there aren't many pharmaceuticals that could be considered curative in that manner. Like antibiotics might be one of them, but most of them just don't offer that deeper benefit that cannabis can provide to patients. So, and working with patients naturally led to me educating medical professionals because my patients would come to me, they would receive guidance, they would start feeling better. They would be logging things like their blood pressure and their blood sugars if they were on medications for those conditions. And then as their blood pressure or their blood sugar or their pain levels or whatever target they were after began to improve, I would direct them to go back to their prescribing physician and say, hey, I don't think I need this pharmaceutical anymore. Can we please start reducing it or take me off of it? And through that, the physician's curiosity, if they're brave and they're not, very pharma driven and stuck in that paradigm, they would be receptive to education and they would reach out to me and say, hey, explain this to me. How is this working? So that's one way where we kind of naturally progress from educating patients to educating medical professionals. And we can really begin to teach medical professionals that the science trumps the stigma, because it does. If you're looking for the research about competent guidance leading to optimal patient outcomes with cannabis therapy, that's the link right there for it. It's on a few pages, I think. So this is our status in Oregon where I live. We were a trailblazer state. We were the second state in the US to legalize medical cannabis through our Oregon medical marijuana program in 1988. And we've had legalized adult use or recreational cannabis since 2014 through OLCC. So pretty much anybody 21 or over can grow 4 plants, no paperwork. They can go into a dispensary, show their ID, and purchase cannabis. So it's very easy to access cannabis in this state. What's not so easy is to get competent medical guidance. It's very difficult, actually. They make it difficult on the patients and the medical professionals in this state. Our current environment, 26 years later, and I really love to refer to the Americans for Safe Access State of the States report because it's very objective, looks at all the states, and actually grades them on their medical cannabis program efficacy. In Oregon, after 26 years of legal medical cannabis access, being the second state in the nation to legalize medical cannabis, we received a 54% grade in 2022. It's shameful. It's awful. We are failing our vulnerable OMMP patients. And I am one of these patients. So I have experienced this process and really understand from the patient perspective how discouraging it is. With adult use, we often have patients that don't want to pay or can't pay to participate in the OMMP program. It can be very expensive for patients that are on SSI or veterans or on disability. So many of them opt to just pay the higher taxes and use our recreational program. And the top uses for recreational cannabis in Oregon are medical, anxiety, sleep, and pain. And I think these are kind of the top uses across the board. I don't think it's specific to Oregon. These are medical uses, yet patients are choosing to just go to the dispensary. They're not going through a physician. They're not receiving guidance. They're just kind of going at it on their own. And if you want to look at the ASA report, the link that is there for it as well. So lacking organ patient supports is really a huge issue. And the certification process is kind of where it starts. Because in order to be registered to participate in the Oregon Medical Marijuana Program, you need to go to a physician that will certify you. It's usually not your primary physician because they aren't educated, and while they might be okay with it, they often don't want to talk about it, don't want to sign for it, don't have the knowledge to educate. And so really the patient from the get-go is on their own. But they need to get a diagnosis from their primary physician because the cannabis physician can't provide that. And then take that diagnosis to a cannabis physician and pay $200 to $300 for that appointment, not covered by insurance. And all they walk away from that appointment with is a signature. Now we think about it when a patient goes to a physician and they get a prescription for a medication, it has a lot of information on it. It has the dose, it has the specific chemical compound or medicine, it has the frequency, it has the route, it has directions, it teaches side effects, it teaches contraindications, it teaches if there's pharmaceutical interactions. Our patients are receiving none of that information. They're walking away with a signature. So imagine if a patient went to a physician to get a prescription, and all they received on the prescription notepad was a signature, and then they're told, oh yeah, just go to the dispensary and pick, or go to the pharmacy and pick something out. And oftentimes when patients go to dispensaries, it's kind of the eeny, meeny, miny, mo method, or they go by what smells good to the patient, which is not, the smell thing might have something to it, but it's not a scientific or well-informed approach at all. They're not teaching about what the science reflects about the different cannabinoids or terpenes and what benefits they might have that specifically fit that patient's needs. The dispensary staff are not educated on really important risk mitigation topics like pharmaceutical interactions and how to avoid them. So, we really need to kind of help change this paradigm to medical is medical, and we need to be serving these patients following our medical ethics. We're not doing that. Not currently. So like I said, there's so much room here for those of you that are helping patients. There's so much work to still do. The Moxon case study is another teaching tool I've used, and I've got the link there on the bottom. This is a perfect storm scenario that happened in 2020. with a patient that was long-term on meloxicam, lots of, individual factors that contributed here. She had been on it a long time. She was elderly. She probably had decreased clearance, so high serum levels of meloxicam. And she was combining it with CBD, which uses the same CYP450 pathway for metabolism, which can create interactions between cannabis and the pharmaceuticals. And unfortunately, this woman switched to a liposomal CBD, which has enhanced bioavailability. And in this case, that seemed to translate to enhanced interaction with the pharmaceutical meloxicam. And 3 days later, this woman began to exhibit a known side effect of meloxicam called Stevens-Johnson syndrome. And she died a week later from Stevens-Johnson syndrome, which is a terrible death. Very, very painful, very excruciating. So once again, we have research supporting that the interactions between cannabis and pharmaceuticals should be screened for every patient that is combining them, because this was completely avoidable for this woman. If she had had competent guidance and had been told, hey, don't combine your CBD with the meloxicam, they could interact, the CBD could potentiate it, make it stronger, and cause you problems. That's exactly what happened. So, we really need to be teaching this to our patients and our medical professionals, who are, of course, lacking education. They're lacking support by licensing boards as well in Oregon. And thankfully, the Oregon State Board of Nursing, as of last month, is now finally supporting cannabis nurses and their work with cannabis patients. But the Oregon Medical Board is still very resistant and still very retaliatory against physicians who are serving cannabis patients, following our ethics, following state law. They're still not on board with us. And, a lot of medical professionals just don't consider cannabis to be a viable option. And so we really need to be getting this into our education. One of the things that I have done to help patients have access to competent guidance is this RAT card. I printed it up and it's in a lot of dispensaries in Oregon. And I also follow that with education for the dispensary bud tenders and helping them understand that they should not be giving what would be construed medical advice to their patients. That could be, a risk of liability to that dispensary. If they give bad advice and somebody happens to be harmed by it or, even scared by it, they could potentially take it out on that dispensary. And so these are the parameters that I teach the bud tenders, like hand this rat card to a patient if they ask you a medical question and say, I'm not qualified for this, but here's a free resource you can call to ask your question. And here are parameters that if you meet any of these, you should actually be getting competent medical guidance. So this is a great way to help reach those patients that might otherwise fall through the cracks and be at risk of, maybe not at risk of harm. I think that's a very low risk, but at risk of potentially, having therapeutic failure when they could succeed with competent guidance. So, it's very, very helpful to have these kinds of resources for patients. So as far as the Oregon cannabis legislative advocacy, this is something I got into. I've hated politics my whole life. But just seeing the unmet needs for patients and medical professionals in Oregon, and really my advocacy started with California Ryan's Law, and even before Oregon. This is where the changes are really made to our laws, and this is where we're able to write legislation that protects patients and protects medical professionals. So this is the reason I got into advocacy. The goals are to protect patients' rights and follow our medical ethics. And this includes upholding their right to autonomy or being able to choose whatever it is that they want to use therapeutically, and their right to informed consent, which means that they have the right to know what are the potential benefits, what are the potential risks of cannabis therapy, what pharmaceuticals should they not be combining it with. There's sometimes even specific, lifespan or condition considerations around use of cannabis that they should know that they're missing because they don't have access to this information. So we need to be providing competent cannabis care and disallowing discrimination. And so the bills that were passed and introduced, I mentioned Ryan's Law, which of course was 2021 in California, that passed, that protects patients' rights to access cannabis while in a medical setting. In 2021, Oregon passed HB 3369, which specifically protected nurses' right to mention cannabis to patients. And then in 2025, there's Oregon Ryan's Law. We're trying to copycat California SB 311 to further support our laws allowing access to patients because currently they're not enforceable. It's nice you go through all of these years to put together laws and get them introduced and get them supported and get them passed just to have our own Oregon regulatory agencies decide they don't have to follow the laws. It is extraordinarily aggravating, but we have to keep fighting. And then we also have another Oregon legislative act that is to be announced. We don't have the number yet, but it's hoping to improve the financial barriers for patients through allowing their registration in the Oregon Medical Marijuana Program to be without cost, where currently it's, $200 to $300 to get the doctor appointment. It's, upwards of $250 in order to register as a participant. And then if you have somebody growing for you, sometimes you have to pay for that. So there's all of these fees that are really a barrier to our vulnerable patients because most of the patients in OMMP are on disability or on SSI or, elderly or retired. So we really need to be making it easier for these patients to participate in our medical program. We're also really pushing to get just basic education required of our medical professionals. Excuse me. Little tickle. Um, now, especially in medical legal states, we are inevitably going to interface with cannabis patients. So what we're proposing is that licensed medical professionals be required to take at least a continuing education or a CME course, enough to understand that cannabis is a viable option, to help decrease the stigma and help medical professionals understand if you don't know enough or you're not comfortable providing this ethical guidance to your patients, then you need to refer them to somebody that does. And don't be diagnosing them with things like CUD or CHS if you don't know enough to be doing so. That right there is going to solve so many problems. We're also trying to get into the formal curricula into nursing schools and medical schools. Because once again, this is proven to improve medical cannabis outcomes for our patients. So this is what our ethics are all about, is that we have an obligation to be upholding these rights for our patients, and we're currently not doing so, even in Oregon, which is amazing. Regulatory advocacy. So the goals here, this is advocacy with the regulatory agencies, is to protect and support cannabis medical professionals and their patients. And this is where we're requiring the medical professional education. My first inquiry to the Oregon State Board of Nursing was in 2015 as a nurse that had begun to formally do one-on-one consultations with patients. And I was advised to follow the patient education guidelines. And so I had my business, Integrated Holistic Care. I had 3 nurses working for me that I had trained that had different areas of specialties to work with cannabis patients. And in 2019, my business was shut down along with every other nurse in Oregon that was serving cannabis patients with a gag order that specified that we were not allowed to discuss cannabis with patients, period, in Oregon, under our Oregon nursing license. So this was something that my attorney and I fought. And in April of 2021, we had that gag order overturned on the basis that it was unlawful, and he utilized Conant versus Walters, the 2004 precedent that protects the right of free speech of medical professionals with their patients as the basis for that. And it was overturned and rescinded. Shortly thereafter, we actually had HB 3369 passed that designated and specified that nurses could discuss cannabis with their patients as long as they had a patient-provider relationship. And interestingly, my next question to OSBN once we got the gag order rescinded was, okay, so now we're back in this gray area where you're telling us to follow patient education guidelines, but there's nothing specifically protecting us and our work with cannabis patients. So can we talk about adopting the National Council of State Boards of Nursing guidelines for medical marijuana nurses? Can we talk about doing this so we have a scope and we're not forced to operate in a gray area under our licensure. And it was about 2 weeks after we broached them, my attorney broached them with that question, that I received notification that I was being investigated for breach of scope by Oregon State Board of Nursing. It was very vague. It was a pretty stressful year of this investigation. It had no specific patient complaint, no specific case file, no specific allegation, like breach of scope, like which of the 60 pages of the Nursing Practice Act were, which line item were they referring to that they suspected I breached, and they couldn't answer that. They couldn't give me a time frame. So they used it as an excuse to comb through 5 full years of my work as a cannabis nurse, trying to find something to discipline me on. And thankfully, I had followed the NCSBN guidelines to a T, crossed every T, dotted every I. And that actually spared me discipline because I was able to say, hey, I followed parameters. The fact that you haven't adopted parameters is not my fault. I followed what I had. And of course, I hadn't, nobody had actually complained. It was very clearly a retaliatory investigation. It was by the former executive director of OSBN, who was notoriously anti-marijuana, according to sources that are close to her. And that's really what drove this response. So what it really did was shut down my ability to advocate for a year, which was really frustrating. But I had to focus on sparing my license. And I did get my case dropped completely. My final letter to OSBN cited like 5 of their own statutes they had breached in the mishandling of my case. So it got pretty contentious. But I was not disciplined. My case was dropped, and it was just about a month later, my license came up for renewal, and I chose to go ahead and retire it in good standing because it was a barrier to my ongoing advocacy. So I retired in boycott of their unethical policies. I also was really not using my license in any way, shape, or form. And I also have some health issues that mean I'm never going to work in a hospital environment again. So those were other factors that definitely contributed. And I don't have any regrets. I've kind of pivoted from there and become a board certified master herbalist. And I'm actually going to graduate school starting next month. And in a year, I'll have a master's degree in integrative and functional medicine. So it's been an interesting pivot. And this really freed me to continue really pushing in my advocacy areas. It's not just a problem with the Oregon State Board of Nursing, it's also a problem with the Oregon Medical Board. And we've had several cases from both regulatory agencies. Oregon Medical Board most recently last year, there was a physician who was disciplined, had to pay $5,000 and surrender his license last year for certifying a minor with autism for our Oregon medical marijuana program, which is completely within the criteria for participation. And the OMB actually pulled a federal ruling to bring into Oregon to this doctor in order to discipline him, which really it's supposed to be the state laws that usurp the federal laws. So they kind of did it backwards, and he just chose not to fight it. He was getting ready to retire. It would have cost him like 60 grand to fight it. So he gave up his license. So this is just a travesty that not only do our patients have to, suffer not having appropriate guidance, but the medical professionals that are walking through those gray areas and walking through that fear and following their ethics and serving these patients are sometimes being punished for it. It's really, really awful. So we have made some progress. Like I said, we got a new Oregon State Board of Nursing executive director who's amazing. She was previously a representative for the state of Oregon, so I had worked with her on some legislative advocacy ideas. And she came in a year ago as the new ED. And in the last year, she and I have been working together. I've testified several times. One of those links is below at the Oregon State Board of Nursing meetings. And last month, they officially adopted the National Council State Boards of Nursing guidelines for nurses in Oregon serving cannabis patients. So yay, I really just applaud them so much. And we're continuing to work with them because they also help to set parameters around what is the required education in nursing schools. So we want to get the endocannabinoid system and anatomy and physiology and in pathophysiology courses. And the director is also going to begin working with some other legislators and the director of the Oregon Medical Board to hopefully release a joint statement that would also help to protect doctors in Oregon. So that's what we're doing right now in Oregon. It's been a pretty exciting month. And then there's also advocacy that I do around medical cannabis inclusion, and this is getting cannabis accessible to our patients that are in medical settings. A lot of what is driving this for me is the fact that I have a 22-year-old daughter with autism who has benefited greatly from cannabis therapy. It's really vital for her and is providing harm reduction. And I talk about and write about that quite a lot. That compared to the antipsychotic pharmaceuticals and the other off label pharma used for autism, cannabis is a harm reduction tool for her. It's alleviating her suffering the horrific side effects of those medications. And in my experience working with so many patients with autism, it's also far more effective in typical cases. It's very rare that cannabis is not more effective than the pharmaceuticals in my experience. So, but unfortunately, she's 22 and she's still living at home with us because she can't go into a licensed care home or other specialized setting because they will not accommodate her cannabis therapy. They actually either disallow it on the campus at all, or sometimes they say, well, yeah, she can have it, but the parent has to come and administer it. That's not respite for the parent at all, number one. Number two, imagine your child is in a complete meltdown, having a behavioral crisis, and you show up and you have to get them into your vehicle and remove them from the property to administer their cannabis. Like that is a safety issue in its own right. It also really prohibits one of the most amazing uses of cannabis for autism, which is the ability to intervene when symptoms first begin to emerge. And oftentimes we can completely avoid the full behavioral meltdown that occurs, but we need to intervene immediately. And it totally negates the ability to do that if you're relying on the parent to drive across town to bring them their cannabis therapy. So these are really big issues with autism, but also for other patients. So through Autism Safe Haven, which is my 501(c)(3) nonprofit, we are working on creating a cannabis inclusive healthcare model. And once we build it for autism, which is one of those conditions where caregivers need to be able to touch the product, we're actually going to have the model set to accommodate any cannabis patient with any condition in any setting. So this is what we're working on currently. And really, our goal is to protect patient autonomy and access to cannabis, regardless of what setting they might be living in or residing in at the moment. Recent issues with the Oregon Medical Facility Licensing Board. This is the board that furnishes the care home licenses in Oregon. Their position is that they must abide by federal law, even though we debunked the risk with that HHS correspondence saying you're not going to lose your federal funding. They are the ones that say they prohibit caregiver touching a cannabis product, which I believe may go to the 280E federal tax. It's like a 40% increased employment tax on any employees that it's specific to employees actually handing over cannabis and receiving money and touching money. So it doesn't apply to caregivers anyway, but they've expanded it to apply, I believe. And they are in full breach of the Oregon medical marijuana law, which protects patient access to all aspects of cannabis care, even when in a medical setting. There is a process for that. So they're just completely shut down and really we're continuing to advocate. And if cannabis shifts to Schedule 3, I expect this problem to just dissolve. So we're just kind of waiting and holding our breaths and hoping that something shifts federally so that we can reapproach them and say, okay, can we do it now? We've been trying. They stopped speaking to me. They stopped responding to my emails. I went to the ombudsman. They started ignoring the ombudsman. So, I've got an attorney on board and she's like, save your money, wait till it goes Schedule 3 and then we'll fight it. So that's where we're at. It's once again, doing advocacy, it can be very time consuming and it can take a lot of tenacity and there can be a lot of frustration. Especially when you're working with legislators and regulators, some who may be medical professionals who have not been educated. So really coming back to, we need to educate you on this. There's a lot of willful ignorance in legislators as well that we run into, and I've got a great example of that. I was testifying at the Oregon Healthcare Committee for the House of Representatives in Oregon. And the co-chair of the committee, while myself and Dr. Rachel Knox and Dr. Adi Ray were testifying, was turned to the side doing this while we were testifying. I mean, on screen while we're testifying, clearly not listening to a word we were saying. I mean, you might as well have been doing this. So it can be really frustrating, but when we look at the need and look at who we're serving, we really need to keep fighting. It's a deep determination in me to make sure that we are upholding our medical ethics and help people understand the ramifications when we don't. There are, the Nuremberg Code is international and they take it pretty seriously. So we need to be following our ethics. So some people believe that, cannabis nursing is controversial, but we do have a lot of support from the American Nurses Association all the way back to 1996, supporting cannabis as a viable medicine, as deserving of research, as medicinal. ANA also asked federal legislators to reschedule cannabis. And in 2023, they actually acknowledged cannabis nursing as a specialty. And I wrote an article in AJAM, the American Journal of Endocannabinoid Medicine, on that topic with the link down below. There is talk about an actual cannabis nurse board certification, although the timeline is very questionable. But all of this kind of goes back to the NCSBN guidelines and using those as a scope of practice for cannabis nurses. So if you're a cannabis nurse, I highly recommend you be following those. Here are the guidelines. I'm going to kind of breeze through them so we have time for some Q&A, but the link is there as well. And then if you're looking for medical cannabis educational resources, if you're an RN to protect your license, one of the NCSBN parameters is to seek repeatable education and formalize your knowledge to comply with NCSBN. So if you haven't sought education, you really should be. JPU, that's the university I teach for. We have a couple of 3-credit courses, college credit courses that you can audit that teach medical cannabis curricula. There's also a master's concentration in medical cannabinoid science. If you're a Cannabis Nurses Network member, there is an exclusive 20% discount that's offered to you. Cannabis Nurses Network also has an amazing advocacy group, and they are actually starting to work with all of the state boards of nursing to try to encourage them to adopt the NCSBN guidelines. So if you're looking at doing advocacy, that's another great resource for you. And there's a link below if you'd like to join. TIOCM, that's where I got my diplomate of medical cannabinoid science. They also have a fellow at that level. I also have, a couple of 3-hour courses on Cannabis Nurses Network that are free with mentorship. And I personally provide a lot of clinical immersion mentorship, and I'm creating a course right now for that as well. So any questions? Let's check the chat.
Oh my God, Jenna, that was amazing. You said all the words we need to hear. That was just incredible. I can't thank you enough for providing this kind of guidance and just so articulate and just hanging on every word. I can't even imagine that that legislative session with Dr. Janet Knox and Dr. Adi Ray, and of course you, like 3 of my personal heroes in cannabis medicine, and just, so
Yeah.
we can't thank you enough for all that you've done and all that you've taught us today. It's immense, and the importance of advocacy, even though you may not experience it in your time. One of the things I did ask one of the researchers at the the Berkeley talk, she's a woman in her 70s, so in her 7th decade of life, and I just related to, a patient situation where, like, if this person had cannabis for his IBS in his early 20s, now the arc of his progressive disease through multiple surgical interventions, multiple pharmaceuticals, multiple hospitalizations, a horrible progression of a disease, and that all that could have been prevented with cannabis medicine. And I said, I wonder if I'll be able to see that in my lifetime. And she kind of held the question while people were talking, and it said the short answer to your question is no, you're not going to see it in your lifetime, Maureen. And it's okay, it was actually okay to hear that. I like my small wins. I like what we do on a daily basis, and I love hearing other people's small wins. Because they all add up, and I just grateful I have sort of a seat at this table of watching the globalization of cannabinoid medicine. So please, please, please raise your hand. Anything, comments, questions, talk to us. We'd love to hear from our participants.
Yeah, there was a question on Ryan's Law, so I'm going to put that link into the chat here. Ryan's Law has passed in California. That is the legislation that protects patients' right to access cannabis while in a medical setting. In California, it started off being specific to patients that that were terminal, and now they've expanded it to all patients who are 65 or older. And I'm stuck. Here we go. Hang on a second. So I'm going to put that link in the chat right now. Ryan's Law.
And then the person who has hand up,
Copycat
go
laws.
ahead.
There's copycat laws for Ryan's Law, and I believe it's almost a dozen states. So if you're not in California or Oregon, where we are introducing it again next year, they can get in contact with me, and I'm happy to connect them with the group that is really trying to push it in other legal states. So it looks like there are a couple of raised hands. Harold?
Hey, thank you.
Yes, of
Thank you,
course.
Jenna. Really nice presentation. My question centered around the drug-drug interaction part, because patients usually take many medicines, and they are usually weaker than regular consumer, and usually the cannabinoids has to be high dose too to have the benefit. So you mentioned this Mexican, this horrible case, right? But my question is, I know there are some drugs, even on Google, you search CBD with other drugs. There's are categories of drugs you should avoid. But um, first question, do we know the severity of if you combine the CBD with those drugs, what's going to happen? Do we really know that? And secondarily, um, how many percentage of our patients already taking those drugs? And if they already do, how do we suggest them? Um, do they have to take A or B, select one from the other? And then another question is for, we know CBD has some issues. How about CBG, CBN, THC, TCB, right? So what do we know about drug-drug interaction? So I think this is a very interesting topic for patients, especially.
Yes, and so my approach is always very conservative, because realistically, whether a patient is going to interact with a drug combined with cannabis has a lot of individual factors. Like what is their liver and kidney health? What is their clearance like? How long have they been on that drug? What are their serum levels? We don't really have all that information. So what I tend to do is use Candir, which I just put the link to that in the chat, which is an interaction guide where you can go in. It does differentiate between CBD and THC. The other ones are still kind of emerging. But I think CBD is really the biggest potential compound that can interact with other pharmaceuticals using the CYP450 pathway, which is pretty common to a lot of pharmaceutical drugs. And it can either potentiate it or make it stronger, or it can potentially cancel it out. So, either way, it might not be a good scenario for that patient. And what I do is I look on Candir, and if they do share a pathway, then I typically look at the half-life of the drug and have the patient space their cannabis dosing that many hours from the drug by the half-life. The thought being that when they hit the half-life, the drug is actually going to start to decline, the levels decline in their system. And so that's going to help decrease that potential for interaction. I've never had a patient where I've always thought, well, gosh, even with that, sometimes patients will say, hey, I'm having this weird side effect and it's listed on my pharmaceutical drug. They may need more spacing than half-life, but that's kind of a good starting point with a conservative approach. Same thing with THC and CYP3A4. There can be some drugs that interact there. There can be combined effects. So this is an interesting thing I learned with working with patients, is that if a patient is taking a hypertension medication, even if it doesn't use CYP 450, if they combine it with CBD, which is a vasodilator, they can get too much of a good thing and they start feeling dizzy and their blood pressure is too low. So
Yeah.
even with combined at the same things with anti-diabetic medications, like CBD will decrease blood sugars. You can get too much of a good thing. So this is where we're teaching patients to monitor and journal. Take your blood pressure every day as you're starting this journey. Make sure you know where it's at. And then they have a journal too and documentation to take to their doctor to say, hey, I don't think I need my blood pressure medication anymore. It's nice and low. So, I mean, there's lots of strategies and approaches that I teach to the medical professionals I mentor specifically on this topic to really just ensure that we're taking a well-informed approach. And realistically, even as medical professionals that are very experienced, we have so much to learn. And that's another reason I really promote that we should be taking a really conservative approach. We should really be using our critical thinking. We should, we don't have a single expert that knows everything about cannabis therapy yet. We still have a dozen research studies emerging every week, and we're learning new information and new compounds and new potential interactions and new uses every day. So nobody knows everything. So it's sort of a conservative exploration, as a cannabis practitioner to really help delineate what is best practice for cannabis medical professionals. And that's where we're at. So it's exciting to be in an emerging um, an emerging field, in my opinion. That's something I really enjoy. So hopefully that answered your question.
Yes, thank you.
Yes, of course. Rebecca, you're next.
Hey, thanks, Janna. Just a wonderful presentation. I'm in Wisconsin, and our new director of our behavioral health, a couple of hospitals, asked me if I would bring to one of our teaching education sessions, our lunch and learns for our nurses, basically, and also the ER physicians on CHS. So what I'm bringing, and we're Wisconsin, so this is like, whoa, this is very, very interesting territory that I'm going into to even bring this to our staff. So certainly approaching it from an educational approach and, the importance of taking a good history and just trying to really connect with what's going on with that patient and get that trust to really be able to then, have a provider say, oh yeah, some of these things might be lining up. So I'm kind of approaching it as, I'm not diagnosing, I'm gathering a history and the importance of that interaction with your patient to then bring those findings. So I'm not quite sure how this is all going to go, and I'm a little concerned, well, yes and no. If there's anything else I should be thinking about, this is strictly an educational experience.
Given that you've been given this opportunity to educate medical professionals, I would include the endocannabinoid science. I would teach them about the endocannabinoid system, this motherboard of our body whose job it is to keep us in homeostasis or balance, and help them understand that cannabis hyperemesis syndrome is actually a reflection that the patient's use is out of balance. That this patient is probably very likely relying on high concentrate THC isolate products like vape pens or dabs that are really not optimal for therapeutic use. I'm a big proponent of whole plant being really optimal, and that goes to some of my herbalist roots as well. It works very differently than these human altered products that we're putting out there. And realistically, the plant itself has an unsurpassed safety profile and is unlikely to be causing the problems that we see with cannabis hyperemesis syndrome. So really, we have this opportunity also to educate the patients and help them understand that their use is problematic and this is the result, and that they can shift that use and potentially begin seeing benefits of cannabis therapy. Usually they have to kind of reserve their use to the non-intoxicating compounds moving forward, unfortunately, but at least we have an opportunity to educate. You have an opportunity to educate the medical professionals who can then potentially educate the patients. And I would say are you a nurse, Rebecca? You're a
Yes.
nurse? Okay. So I would say if, you could also present yourself as a resource and say, hey, if you have patients that are needing guidance, here's my information, send them to me. It's
Yeah, and I really appreciate you were talking about the ECS, because when I brought that up, I'm like, you kind of need to know the ECS, at least a component, in order to understand the CHS and how that all fits together. So this is new territory for me, and it's new territory for our hospital, which again, it's in Wisconsin. We are not a recreational state. We are CBD only. So thank you for everything you do, Janna. You're amazing.
You're very welcome, Rebecca, and feel free to reach out if there's anything I can do to help support your work. I think it's great what you're doing, and thank you for trailblazing in Wisconsin. And I have a family there who's very pro cannabis and doing a lot of advocacy as well. So I'm happy to connect you guys if that would be helpful.
Thank you, Janna.
Of course. Thanks, Rebecca. So we have another hand, Christine.
Hi.
Hi.
I'm sorry I joined a little bit late. I don't necessarily have a question, but I did want to respond to Harold as a patient that sort of treats myself. Something you mentioned earlier, you were saying there's so much room for excitement because there's so much we're still learning. And I think some people might find it difficult because, especially for science-minded, we have a lot of math in our background. We like to have formulas. But like the thing that I find the most troublesome in my traditional Western care is that everybody wants me to fit in this textbook. And it's so frustrating for them when I'm not doing everything that they were taught in PT school by a book. When the nurse practitioner can't just diagnose me immediately out of their new computer system. What I like about this is that it's a dynamic relationship where I feel like I'm truly getting somebody's attention that cares about my health. And so in some ways, even though there might be parts where it's scary because it seems unknown, I would argue if I got all my prescriptions that I've been prescribed since I started getting surgeries for my joints 10 years ago, that those side effect listings would be so much more fearful than a dosage of CBD to play with, you know? And then the other thing that you have to keep in mind is that tolerance changes so much. So that is so unique to the person, but tolerance does change no matter what. So you do have to keep that actually as something that's not like a set treatment plan that's going to be static and concrete. And then the other thing is I'm on several medications that I've been, able to luckily like trim down a lot since I started using cannabis again to treat my pain. However, I just went to Kindle and I looked up all the drug interactions. Almost all of them say maybe weaker or maybe stronger. So there's still a lot of research to be done. And in my experience, I actually haven't found any I actually haven't found any interactions where I feel like one is exacerbating a side effect or like the actual thing that medication is supposed to be treating. If anything, it just enhances it. It allows me to just take less of all of those things. And some of those things it just cannot attack, right? We're just not there yet, or it's just not meant for that. And that is what it is. But it does do a lot of amazing, great things. And it has other benefits to it rather than the pills that I get. So there's also that plus in there. I will say that with CBD though, specifically, I do not find a relief from that with using it separately from CB or from THC. I think that when treating my pain, it really needs to be a holistic experience. So I love what you just said as well about using the entire plant. I tell people all the time, I love trying and need to try every product that I see, all these different methods. I love all the delivery methods and accesses that we have. I think that it's important because some people just cannot have access or be able to use it if it's not in a certain type of delivery method. So I think it's important to constantly be making that better for everybody. But yeah, I've never found it to have a negative effect. Somebody mentioned the others. I think Harold, you also mentioned the other CBs. I will say this though, CBG specifically, I seem to have react better to when I use alone. I actually have CBG tablets that just dissolve under your tongue. And if you take like 2 or 3 of those, you could skip you could skip a muscle relaxer or a Xanax or something. It's very calming. And that has been very noticeable. And then CBN, super helpful with sleep. Also super great for all my friends that do a lot of athletic stuff have been reaching out to me, that don't necessarily have a health issue, but they've been using it for recovery. I live in New York now, but I grew up in Washington, so I have a lot more friends that are much more open and aware of holistic wellness. And so I've been getting a lot of inquiries about that, and I've been excited to hear because I felt the same great I have the same great responses from it. So I hope that helps Harold a little bit.
Yes, thank you. Thank you. Yeah, it's really, like I said, it's individual factors, the shame of it is that CBD is so available. Like you can go to a gas station or a college campus and buy it over the counter. And there's really no, unless a patient understands that it can interact with pharmaceuticals, there's really no opportunity for educating them before they go home and try it. And so this is where I feel like we really need to step up and have well-informed patients and well-informed consumers that understand that there can be interactions. And typically what that looks like, in my experience, is that a patient will suddenly start exhibiting weird side effects. And if you look at their pharmaceuticals, often it's one of the pharmaceutical side effects that suddenly emerged when they started using CBD or THC. And so then they blame it on the cannabis and they stop using it when it's like, no, 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 you could probably continue using it. You just need to space it out and give your body a little break between the two and allow that pathway to clear before the next one hits.
I also need to know your experience level, the amount that you consume, where you
Right.
got your source,
Type of product, is it whole
day, what time
plant?
of the day it is, what your blood
Right.
sugar levels like all of those things can absolutely affect the experience that you're going to have. There are certain things I know I have to eat with food, other things I'm like, oh shoot, I forgot to eat, so let me hurry up and eat something, or like, oh, I'm actually gonna be good, probably. Yeah, there's definitely things I'm like, I start my day with, I know I can have on an empty stomach, and other things I'm like, I need to have eaten and be ready to go to bed, especially actually if it's very CBD heavy, then that does actually make me sleepy as well. And one thing that I do love about CBD, and I love recommending to anybody, is that especially for beginners, if you feel too high from the THC, it will actually bring that part down. And then the best thing actually about THC with all the medications that you might have to take is nausea is almost a side effect on almost every single prescription medication. And if you've had surgeries like me, you know that nausea is like a huge thing to deal with, especially post-surgery. So I
And
like to.
inhaled THC is safe to combine with just about any medication. My
It
husband
really
fell off
is.
the roof last year, broke his leg, and with inhaled THC, he was off the opioids in like 2 weeks, despite a really intense restructuring
Yeah,
surgery of his leg. So
that's
lots
amazing.
of options. I did link my article that kind of explains the difference between whole plant cannabis and the human altered, isolated, liposomal,
Yeah, I'm
whatever.
excited to
I
read that.
call them the bastardized forms of cannabis. There's a
Oh
real
no,
difference
my
in what
hash
you
husband is
see.
crying over here, but
Yeah, the difference in how it works in the body, the difference in the required dosing, the difference in the risk factors and side effects, and the difference in the outcomes. All of those are supported by research. So it's an evidence-based article that I just linked there.
I know a lot of people still don't really know RSO, FSO. They don't really
Right,
know what that
right.
means.
Well,
Yeah.
yeah. Well, and there's no regulation on those terms. So we have like distillate companies whose products, don't have the 500 plus compounds in the flour, like the ones that I use. They're whittled down to maybe half a dozen ingredients and they're calling it full spectrum. I mean, it's very deceptive marketing is kind of the norm in the cannabis industry. So it's no wonder that our consumers are confused on what might be best for them.
Yeah,
Um,
that's
you know,
the biggest problem, I think, just personally, as far as healthcare, as not being able to legalize federally, is that it allows for this to happen so easily, right? Everybody was up in arms about all these vape shops opening, but aren't they doing the same thing with CBD right now? that's another reason why I don't actually really love to buy CBD products either, unless it's from a brand I actually already trust through getting their cannabis product, and then I get CBD from them or someone that I, I'm in touch with and I know that does a lot of research and things like that. But that's another reason why I'm a little bit apprehensive of buying just straight CBD products. Although I did just pick up this drop for my dog, so
Nice.
my dog actually does really well with CBD oil. I give it to her for car rides before we get on the plane, and she loves it. She thinks it tastes great, and it calms her down a little bit.
It's wonderful. Yeah, dogs have endocannabinoid systems too.
I have noticed that CBD does work really well, like for dogs. It's kind of magical. I also think that, when we started studying cannabinoids, we did get very reductionist and pulled them out of the plant and said, oh, this one does this one does that, this one does that. And then, people are making products without exact, the right, the right criteria or the right, yeah, you know what I mean? To
Yeah,
like,
for the effect that you need. I tell everybody I do a little bit of all these things to give myself a full spectrum experience because
yeah.
I'm not necessarily just getting everything at once. Yeah.
But also reductionist is somewhat okay for certain patients, like you said, with the CBG. And sometimes that can, sort of a CBG dose during the day might help you decrease your tolerance on THC during the day or like, but I do agree that CBD has been unfortunately just like not been managed very well, and people will take one and be like, that doesn't do anything for me, and then never try another cannabinoid product again. So again, just everything Janna said, we could just repeat the video over and over and over again because she covered every single point that we need to touch on in order to become better at what we do. So again, Janna, I cannot thank you enough. This was a great presentation. Another example of what Cannabis Public School is bringing, and it is bringing it in hot.
Thank you for that.
Thank you so much for coming today. And this presentation will be available. The notes will be available. The links will be available. And we are coming in with a great fall semester as well. And Janna, again, I cannot thank you enough.
Yes, thank you, Mo. Appreciate you having me. It was good to see everybody.
Yeah. Have a great, oh wait, let me just do my Sunday quote because it's really cute. Let me, sorry. Let's see if I can find it. Da, 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 da. Present. I know most of us have left. That's okay. Go out into the woods. Go out. If you don't go out into the woods, nothing will ever happen and your life will never begin. And I just want to sort of qualify this with who Dr. Pinkola Estes is. She's a distinguished poet, a Jungian psychologist, celebrated for her book, Women Who Run with the Wolves, an amazing book that changed my life as I drove across the desert that she was talking about. She utilizes mythology and folklore to delve into the feminine psyche. Her quote, go out into the woods, go out. If you do not go out into the woods, nothing will ever happen and your life will never begin, encourages embracing both the natural world and life's uncertainties. Estes urges that personal growth, creativity, and awakening stem from stepping beyond comfort zones and fully engaging in life adventures. So go out, my people, go out into the woods. We'll see you next week. Love you all. Bye.
Thank you, Mo.
Bye.
Maria, thank you, Janna. Thanks, Mom.
Oh, were you getting me? Yeah. Action.